Dysplasia.
Yay! Last regular talk and come around full circle to total hips, right? So after listening to 10 hours of preservation, we now get to talk about a definitive surgery for these patients. Joking, of course, but we'll move on here. So again, disclosure, standard disclosures. In addition to this, I'm an arthroplasty surgeon. I'm a metal and plastic guy. So that's my perspective. And I must give you all kudos and credit for listening to 10 hours of measurements and corrections and this and that, where I just go in and take it all out and put in metal and plastic. So you guys all do a great job for these patients. Again, my talk, I was asked to give a talk on when to ask for help. Well, after listening to a lot of you guys, I don't think you guys need much help. So if there's any trainees here, maybe this will be devoted to you. And again, a lot of the borderline dysplastics, you guys don't need help on putting a total hip in those patients. So I will show a few more, Crow 3 and 4 patients as well. But I know this is not an arthroplasty course, so I'm just going to blast through my slides, just power through a couple of these cases, and we'll move on to the keynote speaker. So dysplastic hip, we've been talking about it all day. It is a challenging operation to do total hips, but certainly not as challenging as some of those cases we just saw. Whoa, okay. But why is it challenging? Well, several reasons why it's challenging. Acetabular side, femoral side, neurovascular structure. So on the acetabulum, of course, they can be shallow, small, soft periarticular bone, particularly those that are non-articulating, the high dislocators. Retroverted, as we've talked about, high hip center. Femur, again, we've had several talks on femoral version already, so increased neck anaversion, lower head center, higher neck angles, lower femoral offset, metaphyseal diaphyseal mismatch, we haven't talked a lot about that, smaller canals, and then soft tissue as well. A couple cases were mentioned already with adductor deficiency, neurovascular abnormalities. So complications, of course, it is a more challenging than just a standard total hip. Increased complications include things such as nerve injuries, femoral and sciatic, a lot from traction when trying to reduce these patients, direct injury, hematoma. Femoral fracture, again, from those metaphyseal diaphyseal mismatch, smaller canals. If you're trying just to blast your usual typical implant in some of these patients, that's not going to work. So you have to have a large armamentarium of implants to choose from. Dislocation, of course, with all the different versions that we've heard about all day today, higher risk for dislocation. Leg length discrepancy, of course, heterotopic ossification, you'll see that in one of my later cases, anemia. But given those increased complications done well, patients can do very well with hip arthroplasty. Excellent mid and long-term results and low complication rate, in good hands, done well. Who's going to do those? Again, I was asked to give a talk on when to ask for help. Well, again, I'm biased. I'm a arthroplasty trained fellowship surgeon. So these guys from Rush, that fellowship trained guys, do great jobs for doing total hip arthroplasty on complex patients with fewer opioids. But certainly this group of patients, or this group of surgeons here, I don't think this is applicable to you guys. I put this slide in over lunch based upon our prior conversation, just so I don't get crucified when you see some of my cases here. So we talked about poly thickness. So this was just from March of this year from the Mayo guys. So failures of the bearing surface were nearly eliminated by highly cross-linked and ceramic bearing surfaces here. So these were greater than 75%, 36 or larger heads. Bearing rates have evolved. Traditional failure, such as polyethylene wear, have nearly become extinct. So again, you'll see my cases, I put in large heads. So this is why. So don't crucify me. But please feel free to interrupt at any time. I like this to be as interactive as possible. I don't mind you shouting out, say, why'd you do that? That was crazy. I would have never done that. I'm happy to critique my x-rays. So starting out with some of these, just relatively mild. Again, I don't think anybody here needs help doing some of these very mild or borderline patients just putting in a regular standard total hip. Again, large head, fairly standard hip arthroplasty. Same here. This patient did have a prior osteotomy. Nothing overly special though. Can put in a fairly standard total hip arthroplasty. Again, I'm an anterior surgeon. A lot of these I do from the front. I do all my big revisions from the back, my bigger dysplastics from the back. So again, it's all comfort level. You have to feel comfortable with the approach you want to use. You have to feel comfortable with the implant. You have to feel comfortable putting augments in. You have to feel comfortable changing up your femoral stem. And if you do those things, you can tackle a lot of these cases. Another osteotomy here, an open reduction at 11 months old. So you can kind of see some up top here. Shouldn't be too bad, looks fairly standard. I use robotic assistance for a lot of my cases, so I have the benefit of seeing preoperative CTs on essentially everybody, even when I don't necessarily need it. This case, though, we looked at version, of course, significant version difference between the two sides. I use all these things when I go into surgery, so I can fix my combined anaversion for these hips. So I also go into cases where I know there's a lot of anaversion. I have on backup stems such as an SROM. If I need to change the version of that femur during surgery, I have also the ability to do, say, rotational osteotomies, whatever might need to be done. So all this information in advance is important to know. And then during surgery, I use that. So in this case, I didn't need it. I mutilized the cup a little bit just to get better coverage, but could put in fairly standard implants in this case. Here's another case, prior PAO in 2000. Again, not that every PAO fails, but this patient did well for 20 plus years, couple decades, but went on to failure. Again, preoperative CT scan I think is useful in a lot of these more complex patients to get a good idea what you're dealing with, help planning what you're going to go into surgery with, and what you need to do. But again, after all that, after careful planning, you can put in a fairly standard hip arthroplasty in a majority of these patients. Here's just another patient. We're getting a little bit higher and higher into the Crow classification now, so a little bit more subluxed, a little bit higher riding. Patient here, again, place the cup a little higher, but again, fairly standard. I like this short femoral stem for a lot of patients when I don't need to control version as much. Just moving on, again, a little higher here. So going into this case, I certainly think, okay, am I going to have to do a shortening osteotomy for those patients? I like using the SROM. I like to control that version. I like having the independence of the proximal fixation for these patients. That's how I went into this patient saying, okay, I'm likely going to have to do a femoral shortening osteotomy if I can't get this reduced. Again, very, very shallow acetabulum. Am I going to be able to bring and put that acetabulum back down where it needs to be? And just careful planning, having a lot of different implants available in the OR depending upon what you need. But again, I was able to bring the acetabulum down. I think we talked before about dual mobility. This is modular dual mobility, so I do use dual mobility in my higher, more complex patients if I have any concern for instability. Again, SROM, I didn't have to do a shortening in him, but still had the SROM available, so went ahead and used it. This is, again, a little bit more complex patient here, had the other side done at an outside institution, comes back in. Again, this is some of that metaphyseal diaphyseal mismatch. You have to be prepared to use a lot of different implants in these patients. She was doing fairly well with her other side and liked that construct and didn't feel significantly different leg length. So I'm like, all right, well, I can go ahead and try and match that. So I went ahead and basically just matched her other side. Again, cups maybe a little higher than otherwise, but her leg lengths look pretty good. I cemented that stem in, the version that I wanted it in. She felt nice and stable, still doing well. Large head. A little bit more complex patient here. You may be thinking I'm doing this side. This side actually isn't causing her very much pain. At least it wasn't at the time. We're going to do that side in a few weeks, though, just to balance her out. We started with her right side here. And you look at it, you're like, okay, what do I need to do here? The acetabular side doesn't look that bad. I should be able to put in a fairly standard cup. What am I going to do on the femoral side? Am I going to have to do an osteotomy to get a stem down? But, I'm certainly going to have to take this plate out. You also need to, these are her knees. I only put this slide in here because you need to take into account what's going on distally. So we had several talks about that previously. I won't belabor this point. So this was my initial plan. All right, well, I'll just take the plate out. I'll put in a little Wagner cone. Cup I can probably get in fairly standard cup. This shouldn't be that bad. Well, CT, yeah, that's fairly standard. I can get a cup in there. That shouldn't be too big of an issue. But what I didn't realize, I looked at her cup and I didn't look at further down in her femur prior to surgery. This plate is buried inside her cortex. I could not find that plate at all. Couldn't find it. It took almost as long to get this plate out as it did anything to do the rest of the hip arthroplasty. But the reason I put this in here is I couldn't no longer use my Wagner cone because I had to make a huge cortical window just to get that plate out. I had to take out all that cortical bone in order to get the plate out in order to get a stem down. So of course, put on a cable a little distal. You have to have backup. You have to feel comfortable using alternate implants. And again, one with a dual mobility to get her stable. We'll do our other side in a few weeks. And then just one final case. This gentleman here, 28-year-old male. Again, he has quite shortening greater trocho almost up to the iliac crest. So on this one, yeah, I did went ahead and did the femoral shortening osteotomy. Again, used the SROM. But you say, oh, Mark, this is one I thought you'd critique me on. Why'd you put your cup up so high? Well, I didn't try and put my cup up so high. I actually exposed distally initially to get my cup where I wanted to be. But I ran into those are vascular clips. I ran into a very big vessel during surgery, which bled a lot during surgery. So I did not want to go back in that area. And so I just put my cup higher up. He still looks pretty good in my opinion. He's pretty stable. He was pretty happy with his result. But again, you have to be ready for dealing with all these things during surgery, which again, given some of the complex PAOs you guys do, that should be nothing for you. But as an arthroplasty surgeon, hitting a big vessel where you normally don't expect a vessel can be challenging. So at the end of the day, again, I was asked, when to call for help. It's all comfort level. If you feel comfortable doing these cases, feel comfortable with multiple different implants, feel comfortable with different constructs, feel comfortable putting in acetabular augments or bulk allografts, doing femoral rotational osteotomies or shortening osteotomies, these are very doable cases for the vast majority of you guys. Thank you very much.